Thank you, Dr. Avandi. So thank you everyone for joining us. We have a very interesting case we'd like to show you of an Impella assisted left main PCI, as well as some calcium modification techniques in the right side, led by Dr. Minhas and Dr. Avandi in the room. So the patient case history, 67-year-old male who has a history of chronic kidney disease, stage 5 diabetic nephropathy with a creatinine in the high 400s. He has a history of type 2 diabetes, as mentioned, hypertension, dyslipidemia, he's a smoker, and he has remote bacterial meningitis complicated by some hearing loss requiring a cochlear implant. His current presentation, he presents with respiratory failure, was intubated and ventilated along with some level of acute coronary syndrome with the troponins in the 700 range. There were some challenges with extubation. His EF was noted to be 30%, and due to persistent heart failure, he was sent for coronary angiography. The angiogram was done as per routine, demonstrating a large left main with distal calcification, as you can note, ostial calcification as well in the left anterior descending, and ostial large circumflex disease with some mild disease in the mid-segment. In the spider angulation, this better shows the ostial circumflex angulated calcified lesion in a large vessel, as previously mentioned. And in the cranial angulation, you notice that the proximal LAD does have severely calcified disease with an occluded segment in the mid to distal, which we felt was chronic. The image of the RCA demonstrates a circumferential calcified lesion, at least on angiography, in the proximal segment, which appears significant in a dominant vessel. So the case plan for today was recognizing this guy as calcified left main and RCA and LV dysfunction. Cardiac surgery assessed him and felt that he was not a candidate for surgical revascularization and was brought back to us for consideration of complex PCI. Recognizing his left ventricular dysfunction and his multivessel disease, he had testing done, including a CT abdomen demonstrating patent iliacs at 7 millimeters in the minimal size. And echo demonstrated no LV thrombus, so we thought he'd be appropriate for percutaneous ventricular assist. The plan today, and I'll let Dr. Minhas and Dr. Ravandi take it from here, was a left femoral CP, which was Impella CP, which was pre-closed in a 10 and 2 fashion, as per usual, along with the right radial stem French access for the intervention. And I'll let them take it from here. There, Dr. Minhas, go ahead.
Thanks. We could go to the OCT imaging here. So we've got a French AL guide. We've done a OCT run that we've co-registered. So as Dr. Cass has shown, the RCA has 2 severe lesions and is heavily severely calcified. And you can see that here on the OCT. As we go through, there's a large lumen, some nodular calcium here at the distal end of the mid lesion. And as we get into the segment that's disease, you can see we have loss of lumen and we have diffuse, fairly concentric calcification here. And then we'll go through to the proximal lesion as well. And similarly, there we see diffuse calcification in the little bit of blood swirling. In the lesions, we don't see nodular calcium. So our plan here is to use IVL, and we've sized it, as you can see here, and measured our reference lumen size. So we're going to take a 4.0 IVL to both lesions and do lesion prep and plan to try to treat this with one long stent.
Perfect. Nodule right at the lesion. Should we have gone with an IVL right off the bat, or maybe Rhoda?
Yes, a good question. I think if we had a large nodule that was impeding the lumen significantly, then we would be better off with atherectomy to try to modify that nodule. I think IVL is effective, but if there's a large nodule there, I think you're better off doing an upfront atherectomy.
And what do you think about Rhoda versus orbital when you deal with nodular calcium?
Yeah, good question. I think our group has a lot of experience with rotational atherectomy and less so with orbital. So we've used mostly rotational atherectomy for that indication, but I think both can be effective.
You just cross it.
Yeah, I think we're just across. Let me just give a small puff to make sure we're in the right zone.
I think you're just past it.
Yeah, I could probably come back a bit. The emitters.
I'll give you a puff there just to see where we're landing it. So that actually went pretty easily. I'm impressed.
Yeah.
I usually have quite a bit of trouble with the IVL, almost as big
Yeah.
as a stent to cross.
Perfect.
Yeah, you're right across the lesion there.
Great spot. Okay, I think we could go up to 4. I'll let you do the emitting.
Sure.
Going up.
So with our IVL balloon, we're going to go up to 4 here. You're up, and we're going to start delivering therapy. There we go. See if there's any change in the lumen there. I think it expanded not too bad.
Okay, down 6. So we gave the therapy at 4. We most dilated it to 6.
Let me get the guide back just to flow into that right.
Kick the guide back a bit here. There we go.
Perfect.
So we concentrate the treatments here until we see that we get symmetrical expansion of the balloon.
Can we zoom in on it, take a look at it?
Yeah, sure. Good.
Let's see.
And we'll go up again here.
Go for it.
Up. Yeah.
Perfect. We're going to deliver some therapy here. Right now we're up at 4 atmospheres. The city there. It's actually not bad at all.
It's expanding. It's a big vessel. We measured it 4 by 4.8.
Okay.
Down 6 again. You can see the balloon prep is excellent. We don't see any air in there, so we're allowing the energy to transmit.
Do you want to hit the prox too on the way out, or what do you think?
I think so for sure. I think we'll maybe try to deliver a few more therapies
Sure.
to make sure we get it well expanded. Up again.
That looks even better the second time.
Yeah.
Okay, delivering therapy right now. Good.
It's good. Six.
And a lot of things that help us even delivering such a large balloon in there. AL1 guide, 7 French. We can't get away from having really good guide support. This is really.
What do you think about some therapies distally? Just distal to the balloon?
I think we just got it right, and I think our balloon was even distal.
Small cine here. Let's see how it works. So I think we could.
You're right. There's a nodule there, but I think that we will be able to get away from.
So I think we can treat the prox, and then if we wanted to, we can do an OCT run.
Yes.
Just to ensure we've got proper modification, so we don't end up with a stent regret situation.
I think you're in a good spot.
Oh. Yeah. I think that's a good area.
Yeah, I think you're right. Hanging in at the ostium there. Perfect.
So this is going to be the proximal lesion there. That's up.
Okay. Delivering therapy here. We're at up at 4 atmospheres. So it really helped us to size the vessel appropriately, knowing that getting appropriate IVL balloon size.
It's down 6 again. I think we can just take this out and do an OCT run.
I think that's a great idea. See what the modification is. Let's just fire there. Perfect. And we have some therapies left just in case if we need it for the left.
Thank you.
There we go. I'll give that to you. Perfect. Let's go with OCT next. You got the OCT out there? Perfect. Make sure the catheter is not. There we go. Okay, let's do that. Let's see the difference. Recording. I was happy with the expansion of the balloon, even though it wasn't too high pressure.
Especially in the mid lesion. So I think that's the advantage of IVL, is that if it's sized appropriately, you not only get calcium modification, but luminal gain. In the ideal situation, you could just go ahead and stent at that point without further modification. And we'll see what the area distal to where we shockwave looked like with those small amount of nodular calcium.
There is a little nodule distally.
I agree, though. It's not that large into the lumen, so we could probably I just stent that area. I've got the wire.
You got
Thank you. Buckling a little bit.
Yeah.
OCT.
The guide was getting it in so it does king sneak out of the ostium there.
Let's try that
I think you got a loop
angulation.
there. I think you got a loop in there. There. Watch out, you got a loop.
Yeah, for sure.
Yeah, maybe a bit more clock in there. We can get a guide liner down.
Sure.
I don't want to lose everything.
I think it'll be better. Could we get a even a 6-inch
guide
guide
liner?
liner? Yeah, we're getting some interaction there. So.
Yeah. Yeah, let's try it. Let's get a guide liner.
Sure. Okay, I'll back this out. Get the guide liner down.
I remember last time we pushed it in this thing, the
Right.
RX part of the
Mhm.
OCT eventually gets fatigued.
If you have a look at the balloon up there, the distal nodule is fighting you. That might be a challenge as well.
Let's see.
Yeah. Thanks.
Wire for you. There we go.
Got it. Thanks.
Let me open up the thing so we can see what we're doing.
Should be good there. That's yeah, perfect. And
Let's
then
try
we'll
that.
back it out after. Perfect.
There we go. Let's go back in. Are the Niebert catheters the one with the longer RX port or the shorter one? I forgot.
Yeah, I'm not
With
sure.
the Dragonfly.
Yeah, I'm not sure with what the port is. I think it's a bit stiffer, so it avoids this issue of the catheter buckling when you're trying to go in, because it happens from time to time, especially in an angulated vessel, like an angulated ostial circ you're trying to cross into. Okay, I've got it. Thank you.
Got it? Okay.
Perfect. Let's take it further.
A little bit more, just past the. There we go. You got it. That's a good
We
spot.
can back our guide liner out. Yeah. Maybe position it right about here. Okay.
Okay, whatever you did last time was really good picture. So let's stick to that and just get it out of the loop in there.
Thanks. That's great. Yeah.
Auto calibrate.
Purge the catheter. Okay, great.
Let me know when you're ready.
Just going to make sure we've got a good, I think that should be a good image. Yeah, okay. You can enable it, sure. I got it. Yeah.
Go for it. Good.
Should be a good image. Okay, we'll get this out. And I think we'll leave the guide liner in place to help us in case we have issues with stent delivery.
I agree.
Yeah. Ooh, not a great run. Should we do another run there?
Oh, there's a lot of swirl there.
A lot of swirl. Yeah, it's not very well interpretable.
Let's do another one.
Yeah. Okay.
You got the guide liner there. Might as well.
Yeah, we'll get the guide liner in. Yeah.
Let me
Just
hold the wire for you.
thank you. Perfect.
Going back in, we're going to do another one.
Got the wire.
Great. Perfect.
Great. Okay, it's back. Let's bring the guide liner maybe just to here. Okay.
Yeah.
Make sure. Oops.
Be activated, or is you going to go manual? That was just sooner because
Yeah, I think we'll go manual, should be good here. Yeah.
nice.
Pull back. Yeah. You could hit it.
Oh, sorry. Let's try it again.
Oh, sorry. Just no problem. Here, I can do it. Let's line it up again. Let me just get it.
You passed it. You're good.
Yeah, that's good. Okay.
Let's just do it.
I can do it from
Should
here.
we do manual?
Yeah,
Or
I
should
can
we
do,
do?
I can do it from here. Yeah. Got it. Yeah. Okay.
Let's see.
Yeah, I'll give you this back.
See this quick screen of it.
See the quality of the run. Yeah, it looks better. Yeah, and then we've got the proximal portion with the guide liner. See, give that. Thanks.
There we go.
Thanks.
Let's see. Well, there we go. I see some cracks there.
Okay. Yeah, we certainly have had, let's just quickly co-register that. So then we can, sure, you know what, I guess we're looking for lumen gain as well as calcium fracture. Which, as you mentioned, I think we saw on a quick glance at the OCT. It's not, okay, let's just look at this. Get rid of that for some reason. It's picking up a rendered stent. Not yet, a bit too early. Yeah, so we see here, you know, as we get into this area, we have lumen gain. We've got, there's the wire artifact, but we do see areas of calcium fracture.
That fracture on
here.
top for sure.
Yeah, right here
Yeah.
about 11 o'clock. Large calcium fracture down here at 5, as well as at 8 o'clock, we see calcium fracture. And that fits with what we see angiographically, as well as with the IVL balloon going up, that we've gained lumen. Here we've got fracture back here. So we've got several areas of calcium fracture and, you know, pretty large lumen now, almost 5.5. So I think at this point, what do you think? I think
we try an NC balloon.
Yeah, you want
Maybe
an
a
NC
4.5?
or you want to just stent it?
I'll go with an NC just to make sure.
Sure. You want to take a 4.5 NC balloon?
Let's go with a 4.5 NC.
Sure. We can
Let's
take
do an
that.
ACT. See if our guide liner in there. Yeah, let's go with a 4.5 15. Perfect.
So I think this is a good point of discussion here. I suspect we probably could get away with stenting it, but I think there's nothing wrong with taking NC to nominal, 1-to-1 and seeing, because it is quite a large vessel.
Yeah.
And we can make sure that we don't end up with stent regret or under expansion. Okay, I'll give you that cornea. ACT.
You want a wet one?
I'm just going to flush this venous line here. Perfect.
Perfect. There we go.
Great, thank you.
Going with the 4.5 15. We'll see how it looks. And I think if this is nice symmetrical expansion without any
issue, yeah, I think
issues,
if we take it below
we'll
pressure
go
and
with
it
the
goes
stent. I'll
up.
be happy.
Yeah. Got the wire. Thank you.
Perfect. You get puff there. I think you're right across it.
Go ahead.
Let me know when you're ready.
Go ahead. Perfect.
That's it.
I think you can go up.
Okay, we're going to go up.
I'll take it to low pressure, go to 6, see if it expands symmetrically.
We're going to go up to 6. We're up at 6.
Now let it fill. Maybe a bit of air in there.
Let me just reprep it there.
Yeah, sure.
We're going to go up again. We're up at 6.
Very
Let it
nice.
fill up. Let's see. Oh, that looks nice.
It's good. And you can see the calcium on either side, you know, it's good.
Okay.
And we might as well treat the prox on the way
Yep.
out. You can see we're getting a bit of damping from the guide, so it's probably not perfectly modified yet.
Good.
Perfect.
That's the spot. Going to go up with a 4 or 5. We're up at 8 again. To get an idea where the ostium starts. I think that's perfect.
It looks like a good spot there, I think.
I think it's perfect because you have another 2-3 millimeters right to the os.
Come down, yeah.
Down from 8.
So now I guess we have, we measured it at about sort of 36 when we met our landmark. So we can take a 38 stent. We should be able to cover it. If we're short, we'll put another short stent there. So we could take that 4038 Promus, please.
Yeah, let's get our guide liner situated.
We have it there. We might as well use it.
Oh, perfect. You're right at a good spot.
We're coring the lesion with the guide liner.
So exactly. The guide liner is making it almost past the lesion.
It's a good sign. Just give me one second. A little bit of wire wrap here. Perfect. Great. So I think that's the advantage of being able to image up front. You, especially in these calcium modification cases, you know how much calcium you have, what type of calcium, what type of device you need to use. Do you need to use atherectomy? Can you go with specialty balloon or regular NC balloon? You get your length, you get your diameter, so you can really, we'd pick the stent up front, based on the OCT imaging and the diameter and the length, and we've already picked our post dilatation balloon as well. So we're in good shape.
I think it makes a huge difference. Like this would have been definitely a situation that without imaging, you could definitely fall into stent regret. The upfront lumen wasn't very stenotic. You probably could have gotten away with maybe a 3.0 NC. The expansion, given such a large vessel, would have been misleading.
And we see that, you'd easily be able to open the lumen up, like you said, with an NC that's undersized.
Yeah.
But then, you'll end up. Let's try to deep seed this guide liner a little bit.
Get the guide liner in a little bit with the tip of the. There we go. Perfect.
Okay.
It's a perfect length. We almost be able to cover the whole thing.
Yeah, I think we'll be
based on my eye, it looks
close.
like that bend was.
So let's dip a puff there. If we're short, we can make a decision here.
I think we might be able to get away with one. I'm going to give you a test here.
Yeah, we can come back a little bit there, I think, to get the os.
Yeah.
Sure, try it there.
Maybe pull it back a little bit just to see where the os is.
Let's back the guide a little.
Let me know when you need a puff. Not you wide, isn't it?
Yeah, sure. Puff it there. Yeah, back a little more, I think. Test there. Yep, you can come back a little, I think, still, eh?
Yeah. Make sure your wire doesn't go. You don't have much wire left here.
Yeah, for sure. Try and test there. Let's see.
For sure, you're at the os there. I think
you
we're
want to
good.
do a quick city?
We won't be able to get any contrast in it because you're not going to see anything.
Well, I think distally
Let's
we're
do
okay.
it.
I just want to make sure we don't miss the os.
I think it looks really good.
Comfortable going up there. Yeah, I think that's a good spot.
Let's do it. Going up with our 4038. I'm at 14. It's a little bit of a drift here and perfect.
Wow, nice result. Good expansion there.
So do you want to get our guide liner in? And
yeah, we'll come back, I think, with the
4.5
NC again, based on our measurements. And then we can finish potentially with an OCT run.
Yep.
Okay. Let's be a little careful so we don't damage the proximal edge of the stent.
Yeah, I think we left probably a millimeter in the os. That's pretty good.
Okay, good.
that's a big balloon, probably pulling everything back.
Pull our guideline a bit. We can reposition it after, I think. Oh, perfect. Thank you. Okay, we'll go back.
I think it's a very large artery RCA. I think with this being revascularized the way it is now, gives us a lot more leeway to be able to look at the intervention on the right a little bit more, on the left a little bit more safer.
Right. Okay, perfect.
Go with that NC next. Maybe you can show a picture of the hemodynamics. Oops, sorry. Maybe you can show a picture of the hemodynamics too, just to get a sense of what we have so far.
Close.
I think you're at distillation there.
Yeah, it's just.
You want to see it landed?
For sure, yeah. It's heavily calcified. It's hard to see the stent.
Where stent begins in calcium.
When there's that much calcium, yeah. Just close the frame up there.
Just try even stent boost. I think you're at distillation.
Yeah, we're there. Yeah, we're a good spot.
Okay.
Sure.
Did it come back?
No, I brought it back a little. Yeah,
okay, perfect. Going up there, we're at 10, 12. We're at 14.
So it's got quite good expansion there.
Very nice.
You can see it's in the middle part of the balloon, but probably won't be able to get it fully open. And you can take it up there, please.
Going up again. We're up at 14. Looks very nice.
It's good results, yeah.
It's still a little bit of a taper, but I think we have enough lumen that.
Yeah. Looks good there. Yep.
Going up. 6, 8, 10, 12, 14.
Perfect.
Very nice.
Good.
Okay.
Okay, and we'll get the guideline.
There was very minimal drift in there, so.
Another OCT run to finish.
Does the wire go in it a bit more? Or?
Once I get the balloon out, I think we're just a little bit tight in the system there with the wire. Yeah. Okay, get the balloon out and then we'll get the wire
down. Go.
So we'll finish. If we get a good OCT run, then we can skip
Move on to the left.
angio. Yeah. Should be nice.
Should a little puff, make sure we have nothing extra going on.
Let me just close your Copilot. Go ahead.
Oh, that looks really nice.
Looks very nice. Yeah.
That looks nice.
It's a good calcium modification. Perfect.
Yeah, we'll do one more run on the right, and hopefully this will be enough imaging for us to be able to move on to the left.
Yeah, and like you said, we still have 40 pulses left to use on the left system if we need it. That's the advantage. So. What are your thoughts on using IVL compared to other specialty balloons such as OPN, particularly for de novo? I know OPN we've used quite a bit for stent regret cases, but what do you think about de novo lesion for calcium modification?
I think in lesions, for instance, such as this, it does have a role. Lumen in itself is enabled to get into the OPN in, but I still favor at least debulking it in a way, either with orbital or creating fracture to really be able to get lumen gain.
Right.
So we definitely use it a lot more in stent regret. Right there, you go. Just clock it a little bit. Just it looks like it's a certain angle it doesn't like to go in.
See if we can get the guide liner down to help us a little bit. Be nice. Yeah, let's see.
Now you're getting stent guide liner interaction, which wasn't there before.
Let's try that.
Different angle, trying to get that.
It's the
Does these OCT catheters fatigue like after a certain time? Like after?
I think so, yeah. Especially that sort of plastic part where it's very soft.
We're gonna lose everything here. Didn't get this thing one more time.
Yeah, if not, we'll go with angio because we've already shown the modification here. I think it's there. Maybe. It's close.
Just in a millimeter, but it's the ledge there.
Should go now. We got the guide liner fairly deep. There we go. There we go. Well, persistence.
Exactly.
Okay,
perfect.
Great.
Let's do a new one and review.
Yeah, great. Thanks.
Let's go live view. Let's do all the calibrate.
Yeah. You just purge it through. Perfect.
Perfect.
And we'll just,
I'll let you do the injection. You
sure.
The knack for that.
We'll open our field that way, and go mag down. That way we don't necessarily. Oops. Let's stop that.
Cancel it.
Yeah. Set that up again. Yeah. Okay. 5. Purge. Calibrate. Yeah, it should be good.
That looks good. Let's see. I see such a large vessel. Time difficult to inject with the
manual. Yes.
With the manual.
Let's see how it looks.
What's impressive is on the left, you can see the calcium just peeking through.
Yeah.
I think a lot of swirl.
Yeah, it is. Yeah, for sure. So I think maybe we'll just take what we have on the angiogram.
I think so.
Yeah, I think it's a good result.
One final angio just to make sure we're all good. You put the guide liner back, get the wire back.
Okay.
That's for you.
Okay, go ahead. There's a small puff. Make sure our guide looks good. Yeah, perfect. Yeah.
Ready. Let's do it.
Go ahead.
That looks really good.
I think that's a good result.
That's a fantastic result.
That's a great result. Yeah. Knowing he's a patient with diabetes dialysis, he's going to have a very high risk of ISR and stent failure. So you want to try to optimize the results as much as possible with that much calcium. So we'll switch to the left.
Okay. So we're going to go with our left-sided guide. Let's get you the jail wire.
And this wire should be fine.
That was a really good, I think, demonstration of having very large vessels with diffuse calcium. How impressive is the.
Nice. Go ahead. Got it.
There we go. And it looks like the CP is doing its job. I think we have very stable hemodynamics.
Yeah. Output of about 2.6.
Yeah.
Perfect.
We're on P5 now.
Great. Yeah, for sure. I'll feed it back to you here. Yeah, there. There we go. So I think Dr. Cass has shown the image of the left system. What were your thoughts there? You know, it's LEDs occluded, the apical portion it's not really viable. So I think we had talked about potentially just doing single stent to the circ with calcium modification.
I think a couple of things play a role. Knowing on the echo that there's a apical
You take the wire, please.
akinesis and thinning of the vessel. So likely the distal LED is, or even mid LED is not viable. That's one thing.
Right.
And again, you mentioned that patients with dialysis and large arteries of stenting usually is a recipe for restenosis, especially in an area like that.
Mm-hmm.
So our goal beforehand was just to aim for the circ, make sure we get a very good result, keep the LED open. If need be, we can go with a provisional strategy and maybe balloon the osteoma of the LED just to keep that.
Right.
There's a very small diagonal, a couple of sepals coming off the LED.
That's right. Yeah.
Just to keep those open.
So it looks a good spot. What do we do?
Still a little
thinny. See where the lay of the land is here. Yeah.
That's a good shot. Can we have the monitors a little bit further back as well?
Are you able to just bring the monitors down to his feet, please? Thank you. That's great. Thank you.
That's great. Yeah, let's take a look.
Save the best for last.
I know. Very tight circumference. I think there's actually a nodular calcium right at the distal left main at the ostium of the circ.
Yeah, often there is in that spot. Yeah, it's difficult to modify.
You can see there's a shelf of calcium within the LED.
Mm-hmm.
But I think our major concern is making sure that circumflex is
it's a huge territory for him.
Again, I suggest just wire.
I think we balloon
OCT.
Yeah.
And
so,
then
can you drop us a fresh Rio 15 NC? Sorry. Yeah. Thank you. Yeah, we need a bit of time to work there. We don't want to go straight with atherectomy, I think, in that situation.
Yeah, let's get some breathing space, as they say, through that vessel.
Thank you.
I got the puffs here for you. Once we get the wire in, I think the wire probably needs a bit of shaping.
Yeah, I'll take the introducer back there. Thanks. And here, you know, we think there's a nodule there. What are your thoughts in terms of atherectomy devices?
Again, see how much of that lumen is actually the nodule is into. If it's really obstructive lumen, then we might have to, hopefully, which was our pre-plan to do, or ROTA, we'll take care of it.
Right.
And again, based on the size of the vessel, I would go with a bigger burr.
I think so. Yeah, I don't think that taking a 1.5 is going to make much modification.
Yeah,
that's good. We're good.
Yeah, we got it. That looks pretty good.
Good.
Okay, so let's try with that
3.0.
We'll go with that 3.0. Get some room to get our
give us some time to work. We have the CP in, but I think we want to still, even with the hemodynamic support, we want to minimize the amount of ischemia we're causing.
Right. I'm not sure even OCT would even cross that.
Probably be obstructive. Yeah. Got the wire. Thank you.
Perfect. Let's see how this goes in. Oh, that was not that
perfect.
Not at all.
A little further. Yeah, sure. Go ahead.
Going up there. Gonna go up to 12. That's expansion there.
It's melon seated a bit there. We'll come back.
Let's pull it back.
It's down 12.
You think it's much more fibroelastic than we think?
I think knowing his underlying conditions and the angiogram, I think it's going to be a lot of calcium there. Go ahead.
Going up there. Let's see. I'm going to go slow.
Slip.
Perfect. We're at 12. That looks good.
I think we'll try an OCT run here.
I agree.
Yeah, let's see what we can learn. Great. So we'll go with OCT here to the circ. And your thoughts on that mid lesion past the proximal OM?
I would leave that alone because I think knowing sometimes less and more, I think is very true in this case.
I think that's, yeah, I agree. I think that knowing we are starting with a very high risk of stent failure because of the underlying conditions.
Oh, that looks pretty good.
Surprised how well modified that is. Yeah. So I think, the imaging will be important here. If we find that we don't have as much calcium as we think, maybe we can modify it again.
I would still give some IVL. You think IVL?
I think
Should
so.
We go to 4 at least?
Yeah, I think at least, yeah, but we may not need to use atherectomy here. So I think it's just everything pieces together. You see the angiogram, first you see the patient, it's diabetic, a dialysis patient, you see the angiogram, but sometimes the proof is in treating it. You don't lose much if you take an NC balloon.
I agree. Let's see how many runs we can get out of this catheter.
Well, you know what they say, we've paid for the catheter, might as well use it.
Of course.
So again, I think that shows, probably we're in good shape because if there's a large nodule, it would be a bit harder to cross with the balloon and the. Okay, sorry.
I'm impressed with the robustness of these catheters. They can take a lot of wear and tear.
Yeah. Okay.
Perfect.
I think we're in a
good
spot. That's great. Each of these, we're not using a lot of contrast here either.
No.
We're manual, but we're not having to use too much. Good run.
Lesion look, now that you straighten it with the wire, it looks a little bit more.
Let's keep our eyes focused up top, maybe.
Don't look at any other lesions.
So interesting, even on the, when it's reconstructing on the long view there at about 25, you see a large protrusion coming into the lumen, which is likely a nodule in our area. So let's see if we can just quickly co-register this. I find it always helps to co-register the image. Yeah, okay. Great. Okay, so it's failed to land. Okay, no problem. So we'll just look at it ourselves here. Oh, I think it's not. We'll have to move.
There you go.
Okay, so if we pick a landing zone.
That's actually a good landing zone.
Yeah, I mean, there's a little bit of eccentric calcium here, but huge lumen. So I mean, realistically, even if we landed it here, we'd probably be fine. Let's see what's going on here. All right. Yeah. So some balloon injury. Yeah. Back into the main.
Left main back, it doesn't look too bad.
Yeah. It's pretty large too.
It's right at that osteum. That's just want to see whether you show the osteum. I think there's a lot of volume of plaque.
Mm-hmm. Let's just increase our field of view a little bit. Let's see this a bit easier. Yeah, it's don't really see.
Should we try our for IVL?
I think we'll IVL. Yeah, I don't really see a large nodule there. We probably have a dissection plane from the balloon injury. So I think we'll take an IVL for oral IVL. Yeah.
What do you think the LED? It looks like there's a lucency right in the middle of it. Is that calcium or?
It almost looks like it's a recanalized.
Yeah, I think it's a double lumen do a cranial view.
Yeah.
I think the ostium of the LEDs actually is not as bad.
Yeah, it looks better than on the original angiogram. I agree.
We might get away with just crossing it across from the circuit to the left main.
So we're getting 3. It's a bit eccentric there, but I'm sure we could take a 4.0 in there. Okay, why don't we take the IVL?
Okay, we're going to go with the IVL one more time. There we go. We got it nicely packed here. And if we're happy with the expansion with this, Yeah, sure. Let's do an ACT.
Sure. Thank you.
There we go.
Get this off the venous line.
Very stable hemodynamics. I think we're still at P5. 2.5 liters. We had, I think one of the key things was in the beginning, the EDP was quite low. So we had to fill the ventricle a little bit to actually get the...
right, which is a bit counterintuitive in a dialysis patient, but otherwise we would run into issues with the pump.
I think our patient had dialysis right before, so...
We'll let the nephrologist know he's well dialyzed.
Exactly.
Looking at the OCT, I think we'll take it distal. Our distal marker, I think that area, we can probably go further distal because it looks like it's almost a 5-0 vessel distally.
I think so.
Yeah.
That way we're not going to have any surprises. If your IVL goes up nice and symmetric throughout.
I think we're in good shape. Yeah. Got the water, thanks.
Get this thing out.
Yeah.
Give it a bit more.
A little bit of slack, yeah.
I always wondered why is the ostial segments of circumflex is always the nemesis in terms of restenosis. That's a spot.
Right. I think that's a good spot. Yeah, we got the.
I'm going to go up there. I'm going to go up to 4 here. I'm going to go up with the IVL. We're up at 6 actually.
Let's come back. I think it's just melances so instead of giving the therapy. Yeah, we see that often. Osteal circ. I think that's very common that we get a little bit of nodulated calcium or calcium we can't expand.
I go slow here.
Good. I'll keep some back pressure on the balloon.
Gently. I'm going up to 2. Well, there we go. It's a little bit of, it's coming back again.
Let's bring it more in. Yeah.
Yeah, just leave it there. See if it pops back.
Go ahead.
I'm going to go up slow here. 2, 4. I think it's not bad. Let's do some therapy here. We're at 4. Tiny bit of waste there.
Doctor, just to let you know, there's about 5 minutes left to the planned transmission.
Oh, 5 minutes. Okay.
However, we are still going to record locally so that we can have the case info for the website.
Great. Thank you.
Thanks. I think we'll give all the therapy.
You want to come all the way to the left main just to make sure?
Yeah, I think because
it's the left main. There's nothing. Yeah, if our 4 goes nicely in the left main. Pull it back and just straight into the left main.
Sure, I think you're good there.
That's it.
That's a good spot.
I'm going to go slow so it doesn't jump back forward or back. Excellent. Okay, we're at 6 here.
Oh yeah, that looks quite good.
That's very good. What do you think? Cutting balloon? Are we happy with another OCT or just stent?
I mean, we've got great expansion here. We've just sized it with OCT. I think we just stent it at this point.
I agree. Should we wire the LAD or no?
We could take it down. Let's take a cranial view, as you said. I think that'll demonstrate, there's not much distribution to the LAD here.
Yeah.
And as you said, the ostium looks like it's in good shape. I think that's good.
Yep. Yeah, let's go with angio, cranial view, caudal view, and we'll go with our stent. I'm already thinking about that mid segment. Once you put a large stent in that proximal, it's going to be a different story.
Absolutely.
And I think you have some straightening artifact too from that. Perfect. Yeah. Wow, it looks impressively smooth.
Wow, that's
very nice.
Very nice to modify. You can see it's still a bit eccentric, but we've really modified it nicely. I think we could probably go. We don't need to come down too far.
All the way to the aneurysmal. I agree.
Because it's gonna
4028. You think?
Where we've measured on the OCT, it's 12, but I think it's not perfectly co-registered. So I think 24, 28. Those will work. So let's take a look at
for you.
Yeah, let's go ahead.
Ready. I think that's just a shelf of calcium that's
right, and you can see the apical LAD filling late. That's DPCs. So I would just go provisional. I wouldn't, wire or balloon the LAD.